Welcome and thank you for attending the Discovery Cafe session, Applying AI to Save Lives During the Opioid Crisis. We have 75 minutes for the session today. That includes the Q&A portion. Our moderator here has been equipped with an iPad to take questions from you that you can submit through the mobile app. We are pleased to have a record turnout this year, and I've been tasked with the role of keeping us on time and getting us out to the next session at the appropriate time. It is now my pleasure to introduce you to your moderator, Dr. Thomas Sequist.
Okay. Good afternoon, everyone. Welcome here. And so we are going to be talking about artificial intelligence and its use to address the opioid crisis. And we have a really wonderful panel of speakers. I just want to open up with a couple of general thoughts on this, and then we will turn to have our speakers introduce themselves briefly and hopefully have a great discussion this morning. Just for background, I'm a primary care doctor at Brigham and Women's Hospital. I'm the head of quality and safety for Partners Healthcare, and have worked with a bunch of our leaders across our system around addressing the opioid crisis. When I think about artificial intelligence, predictive analytics, machine learning for opioids, and improving our use of opioids, making them more safe while still controlling patients' pain, there's a couple of angles that I think about it around. One is, how are we using this approach to understand how our physicians think about and do prescribing of opioids? And the second framework that I think about it in is, how do we use machine learning, predictive analytics to understand from the patient side of things, from the patient perspective, what are the risk factors that they have, who may go on to develop substance use disorder, who may go on to develop adverse events from the use of opioids, how do we optimize the use of opioids from the patient's perspective? There's a lot of really interesting work going on all around the country, from using artificial intelligence, machine learning to figure out what is the way in which we approach pain management in the hospital. If you think about postoperative pain control, there are many, many different approaches to how pain is controlled in the postoperative setting, even within the same hospital for the same surgery. There's a lot of work that's going on around understanding what is the way that we optimize that pain control. When do we start doing pain management in the preoperative setting, in the intraoperative setting, in the postoperative setting? There's a lot we could learn from actually what's going on in routine practice right now to figure out how to optimize that pain control pathway. It's also really equally important for us to be able to predict who, not only who needs what types of medications for pain control, but who will, when we're using different pain control options, will go on to develop adverse events or substance use disorder. Again, there are some predictive models that can help you develop risk scores that you can take into your clinical practice to have some idea of it. But I think that we really, there is a lot more that we could do to understand the levels of risk that are associated with different types of pain management regimens, and whether or not we can use that in real time to drive better prescribing. And the last, and I know we're going to talk about this a lot this morning, but understanding the physician decision-making process, or I shouldn't say just the physician, but the prescriber decision-making process when approaching a patient who has pain, and what are the best options for us. When we look at the patterns of prescribing among physicians, it's clear that, again, there's a lot of variation, but there's real learning that we can get from that variation. So we shouldn't, while we often think in quality and safety improvement that variation is something that often doesn't lead to great outcomes, this variation that we have around pain management right now is something that we should try to exploit so that we can do a better job of learning what is the best pathway forward for pain management. So with that context, I think we're going to have a lot more discussions around this. The first thing I want to do is turn to our panelists and just have them give a very brief introduction of themselves, just so you know who you're talking to today.
Hi, I'm Bob Burgin. I run an alliance of 10, just soon to be 13 health systems who are training in a common platform on complex topics of hospital-acquired conditions. We try to do clinical knowledge engineering and predictive analytics, and we've recently taken on opioids here at Partners, who's one of the founding members, and we have found some interesting analytics coming out of that.
Great, thank you. Sarah?
Great, I'm Sarah Wakeman. I'm a primary care doctor, addiction medicine specialist, and medical director of MGH's Substance Use Disorder Initiative, which is an effort to redesign clinical care for patients with substance use disorder across the healthcare system. And then I co-lead the substance use disorder work for population health management at Partners, and co-chair the Opioid Steering Committee with Scott here at Partners as well.
Hi, I'm Carm Huntress. I'm the CEO and founder of RxRevu. We call ourselves a prescription decision support platform, which you tend to not hear, but essentially what we do is we are focused on the problem of systematizing prescribing. It turns out providers are not really great at remembering dosages and durations of specific drugs. So our platform helps guide them to the right decision. And our core business today is really focused on real-time price transparency at the point of care. So getting real-time patient cost around what they're going to pay at the pharmacy for their drugs. There's a lot of challenges working in that small window of time in that workflow about guiding a provider to the right drug at the right cost for the right patient for their condition, and that's what our business does.
Good morning, I'm Scott Weiner. I'm first and foremost an emergency physician at the Brigham. I have several roles. I'm the director of our division for public health and health policy. I'm also the president of the Massachusetts College of Emergency Physicians currently. But my passion and really what I concentrate a lot of my work on is around opioid-related issues. I'm the director for our hospital's opioid stewardship program, which is called BCOR, or the Brigham Comprehensive Opioid Response and Education Program, which is why we call it BCOR. And then I get to co-lead the Partners Opioid Steering Committee with Sarah. And I've done a lot of research around opioid prescribing, and particularly working with prescription drug monitoring programs, and hopefully we'll get into that in the discussion.
Great, thanks all of you. So I'd like to first start off, Bob, if you could tell us a little bit about the program that you started to help us understand what physicians or prescribers' real knowledge is around opioid prescribing.
Yeah, so we take very specific knowledge engineering, knowledge that needs to be measured and uploaded into the expert mind, but we also measure what we call confidently held misinformation, where providers are sure but wrong. And then we measure struggle through the journey of uploading that information to identify outliers or patterns. And we built the course with Partners Health around safe opioid prescribing. And we produced these visual, what we call heat maps of both confidently held misinformation and struggle. And when we first pulled up the heat map from opioids, the patterns didn't match any other patterns we'd seen. So we were looking at central line-associated bloodstream infections and C. diff and surgical, and there were patterns that you could predict you would see when you pull up the heat map. When we pulled up this visual heat map on physician prescribing, we could not find the pattern. It was what we called scatter. And finally, the folks at Partners, Dr. Bob Birnbaum and others, found the common thread. And it was a bit of a shock to me, although some people are less surprised. The pattern of confidently held misinformation and doubt is not a function of common knowledge. It's not a function of which department you work in. The only common predictor of your misinformation as a physician or knowledge gaps is what year you went to medical school. Wow, right? So if you think about opioids, with the transition over the last 20 years, frankly, from misinformation arguably being put into the market to where we are now, the opportunity to understand how to safely prescribe opioids is there. And yet the knowledge foundation from which the physicians are working is it actually fell into almost clearly 5-year increments from 20 years ago and 5-year increments to today. And so we modified the course, and now we're rolling out across the country with this new insight. But that'd be the first insight I'd say we found.
And what do you think when you find that kind of confidently held misinformation? What's the next step in that?
Well, so the learning system is designed to remediate. It doesn't always work. And so there's an AI engine of sorts. AI is a complicated word. I don't really claim AI. I'm not sure anybody can yet. But there's an engine watching underneath that does things that humans can't do very well, which is a multivariate analysis in real time. So it's watching the intersection of knowledge, confidence, engagement in the content, and struggle to learn dynamically in real time through the learning cycle. And there are patterns that we've identified. We've got about 2 billion learner interactions now on the platform, and we did a 1.2 million learner study, and there are patterns we've identified that certain kinds of struggle translate into an inability to put the knowledge into practice effectively. It tends to be about 5 to 8% of learners on about 25% of the content. And so the system then produces, as part of this clinical knowledge engineering toolkit, produces intervention reports that allow someone to sit down with a provider for 5 minutes and say, this is an area where it appears this is really difficult for you. Let's talk this over.
So so you take a lot of complicated data that comes from, these are physicians taking a quiz almost, correct?
Yeah, it's an interactive learning platform that uses quizzing as part of the learning.
So I'm going to turn a little bit. So Scott, so you practice in the emergency room. How would you see this being applied in a clinical practice setting, this kind of knowledge engineering?
It was interesting. I actually took the course, and I got through it really quickly. So first of all, just speak about that. The nice thing about this platform is that instead of just going very linear through the whole model and saying everybody is going to watch the same slides and answer the same questions, it prompts you for your knowledge. And if you know something, you jump to something different. And so that makes it much more efficient. I think I did it in 8 minutes, which I was happy about.
It's not a record.
Yeah, but we're especially in the emergency department, we're looking a lot at prescribing amongst different providers, and having this background about this of like when and where you trained too is also a key element in this. And I guess what I do is just to shed light on it is the most important thing that this knowledge gap exists, and we can target education for certain generations of providers.
So one thing that I would imagine is, as this is based on the information you're getting feedback on is based on this platform where you're sort of asking questions and it's probing further and further. But one could imagine that if you had real powerful real-time analytics, that it would be able to, through the electronic health record, sort of analyze the clinical scenario that you're in right now and guide you down a better pathway. Let's say if you're in the emergency department and you're treating low back pain or kidney stones. Do you think that that's a possible application?
Oh, absolutely. So what we have right now is we have this wealth of information, and it's very hard to put it all together. So when I see someone in the emergency department, I see the patient, obviously. I see their vital signs. I can sometimes see a list of past medical problems. If I want to, I can look in depth and look back into their past medical history and their records and their notes, which takes me more time. If I want to take another step, I'll look back and I'll see access medical records from other institutions, which some of them have sharing and some of them don't. And if I want to go further, I'll look at their prescription drug monitoring data, which is statewide data to look at their prescriptions. That's asking a lot, right? I have 15 minutes to see this patient with back pain and make sure that they're not having an emergency and that they need to go urgently to surgery, or if it's just a back strain that needs some Tylenol. So being able to pull all of that together and then showing that information in a digested format to the providers, I think would be very powerful. That's something that's where AI could really work to our benefit.
Right. If we switch gears a little bit, so on the opposite side, thinking about it from the patient's perspective and from a population management perspective, there's also tremendous opportunity to take a lot of different pieces of data and through analytics figure out who are the patients who are most at risk in our system of adverse events, of adverse consequences of substance use disorder. And I think about population health management efforts in this space, and Sarah, I know you've done a lot of work in this space. Could you just give us a sense of what is the current state right now in population health management around substance use disorder in terms of our ability to identify patients who are at risk who may need more tailored therapy plans?
Yeah, I would say very early and underdeveloped. I think most of the kind of predictive analytics that's happening, if at all, around opioids is really around prescribing. So it's looking at, some people are beginning to look at, can you predict who's likely to stay on an opioid? So if you prescribe an initial opioid, for example, during a surgery, we can predict that certain patients are more likely to be on an opioid in a set time frame, so 90 days later, a year later. That's really a tiny slice of the pie and is not actually getting at the patients that I worry about, which are people with opioid use disorder and people who are at imminent risk of dying from an overdose right now in the midst of the drug overdose crisis. I think one challenge is in the substance use and prescribing space, we're late to using things like predictive analytics. And within medicine, we're late generally thinking about the overdose crisis. So we're still talking about prescribing, even though that's not actually what's driving deaths right now. So the crisis has already transitioned in that we're in sort of the third wave of the overdose crisis where people are dying from illicitly manufactured fentanyl. Those those are our patients. And so I think there's a huge opportunity to think about using predictive analytics to identify first patients who have opioid use disorder, which we don't do a good job at identifying them in the healthcare system, identifying who's accessing treatment, for those on treatment, who's being retained in care, who's likely to fall out of care, who's at highest risk of dying. I mean, there's so many clinical variables that we could be doing a better job at. And one thing I worry is that often the way we've set up some of these tools is really to identify patients where the answer ends up feeling more like not caring for them. So if the question is, should I not prescribe opioids to this person because this person is at high risk? We're not asking the question of how do I take care of this patient who potentially has an opioid use disorder? And I think the same ideas that you mentioned about sort of thinking through chronic back pain could help providers think through how to care for someone with opioid use disorder, which most physicians really don't feel comfortable doing.
So do you think that it seems clear that we haven't progressed. We've progressed more in understanding physician prescribing and analytics and learning around that space than we've progressed around understanding who are our highest risk patients and how do we provide good care to them, even in the setting of them being at risk for substance use disorder or other adverse events. Do you think the barriers there are more technical or social in nature? So do you think it's that we don't have the right data fields and the right capacity to do the analytics, or do you think it's that we're sort of still just, when I say social, I mean we're still sort of latched onto the idea of this is a prescribing issue and let's just work on the prescribing?
I think the bigger barriers are probably the latter, the fact that recognizing this is not just a prescribing issue and a lot of the stigma and misunderstanding about caring for people who use drugs and people with opioid use disorder. I think there are some data gaps. I think most systems would have a very hard time telling you what percentage of the patients they take care of have a substance use disorder. We're not screening for it. We don't diagnose it effectively. Our diagnosis code data is limited. And so in that way, I think training physicians, training systems to better identify patients would really help us. Because if you think about sort of care cascades with HIV, for example, the first step is making the diagnosis, then starting treatment, then keeping people in treatment, and ultimately, hopefully, improving clinical outcomes. And we haven't even really mastered that first step in the health system. So I think there is some room for growth around the data collection piece as well.
Great. So, Carm, can you give us a sense of where do you think the sort of standardizing of prescribing of opioids fits into this space where right now it is not a very standard process. And there's lots of things that contribute to that variation that we're seeing. But how can taking a process that's quite variable and standardizing it improve outcomes in this space?
Yeah, it's interesting because I get back to the whole thing around variability. When I actually started RxRevu, one of the first studies I looked at was on prescribing patterns where they could actually take pharmacy claims and just looking at their prescribing patterns and tell the doctor what residency program they went to, which is fascinating. And it actually worked 30 years back, which was a fascinating study. And so, you know, we're in this stage where you've got a high amount of variability and very ingrained behaviors. And, you know, the challenge is here, we want to move to this very technologically advanced world where we're systematizing and standardizing, and to your point, right, taking all this complex data and rationalizing in a few seconds to help you make a really informed decision. The challenge with that is typically a last mile challenge, is like, how do you get this in front of the doctor in a way to get them to make an informed choice? The problem today is, well, we can usually get to the data, and now we're actually starting to see some really great algorithms come out, whether it's predictive of is this patient going to become addicted. Interpreting that is a really hard thing, and we've tried to do some, I'll give you an example. We've tried to do some predictive models with diabetes prescribing and managing A1C. When we built these really cool models, we took like 250,000 patients' data and we ran it through a machine model, and you could plug in all these patient factors, and out would come out this sort of probability of what their reduction in A1C would be. And you'd show it to a doctor and they go, I have no idea what to do. And so I think the challenge from a technology perspective is you have these very short windows of time to present very precise information that leads to a really informed choice, and you can't control it too much. I mean, I think this is an important thing, right? This idea of kind of what I call informed autonomy, where if we sort of like push the doctor to a choice, they sort of go, wait, no way, I want to feel the control, right? And so there's this balance of informed autonomy that we have to get with doctors, where we give them all the information in a nice little package, and then they really feel like they're making the choice in an informed way. And they're dealing with a lot of factors computers have a hard time getting at, which is the social pieces, right? The empathetic pieces of with the patient and where they're at and what's really going on for them. And so I think we've got a long way to go to sort of figure out how to deliver this information in the right way at the point of care to really drive that informed choice by the provider. And we're in the early stages of it. We're still, I don't even think, that sort of AI future is out there. This initial thing is sort of, I think, getting some of these risk scores, but in a way where we say, hey, okay, now I can take that information and put them down a clinical pathway or a choice that's going to lead to a better outcome. And I have some confidence that doing that, this information will lead to that outcome.
So I just want to touch on something you said, and going back to a point you made, and there was a question from the audience which I think is a good one. So you suggested that we can predict my opioid prescribing patterns by knowing, let's say that I trained at the Brigham.
Yeah.
And you had said that you can also predict it based on just what year you trained. Can you just clarify which direction the effect is in? So if you trained a longer time ago, you have more confidently misHeld information or less confidently misHeld information?
If you trained 20 years ago, you have a very high rate of knowledge gap, meaning you say, I just don't understand this. This is a very high-end healthcare facilities last December. If you trained 20 years ago, you have about 70% knowledge gap. If you trained, I'll jump all the way and it's a path down, but if you trained in the last 5 years, about half of that 70% became confident, accurate knowledge. But about half of it became confidently held misinformation. So it's about 35 and 35, which is an interesting dynamic, right?
And is that unique to opioids, or have you seen that in other conditions, that same pattern?
We see the pattern, but it's more pronounced with opioids than anything I've seen.
And I wonder why that would be. I don't know if anyone has
Well, I
thoughts on
think
why.
there's some promotion of misinformation 20 years ago was part of it.
Yeah, certainly. I started training around 20 years ago, and for dental pain, I would start with some Tylenol, and the next year it was Tylenol with codeine, and then the next year it was oxycodone, and the next year it was Dilaudid, and it just kept getting more and more and more. You could see it happening. And I'm very interested in what both of you said. It's kind of this social norming thing that happens as well too, and we've seen it in the Brigham ED. We basically started showing the providers their prescribing rates compared with their peers. And we didn't tell them the identity of their peers, but we showed them where they were amongst their peers. And a couple years ago, we used to prescribe about 15% of our discharged patients with opioids, which is quite a lot actually. And then when we started this endeavor, we were down to about 5 or 6%. Just by showing the providers where they are compared to their peers, we've reduced the outliers, and then we've also reduced the overall rate as well. So now we're down to about 3%. And the interesting thing that the dynamic what we have in the academic medical centers is the younger generation. And they're the ones that are pushing us to do better for patients with substance use disorder. They're the ones that are encouraging us to get our waiver training so we can prescribe buprenorphine or Suboxone. And so I think that generation is influencing the older generation just by being there and being passionate and knowledgeable about this.
Yeah, it's interesting because, what we've, to your point, there's kind of like 3 things we found if you want to change provider behavior. You got one of them, right, which is, showing them compared to their peers. It's almost they always want to do their best, and they're somewhat, I would argue, competitive in nature. The 2 other things that we've really been, has surprised me in the work that we've done is, it's not necessarily related to patient, right? The patient, it's really about reducing clicks and cognitive load on the doctor. Mm-hmm. And so that's a key thing that we really work on is hey, if we're going to introduce a new workflow or introduce this type of information, you've got to really pay closer. Am I increasing the number of clicks the doctor has to do to get to that information, right? Because this is the challenge with the PDMP data, where sometimes you have to, I've seen it where it's sort of buried down, and it's there, it's just really hard to get to, and that's a really important piece of data providers need today. And the second thing is cognitive load, and it gets back to this thing of how do you present the information in a way that's really digestible and actionable very quickly. And if you overwhelm the doctor, how many patients do you see a shift, right? 25, 30 patients. You're going like, pretty fast through those patients. And so if I increase your cognitive load, I'm just draining you, right? And by the end of your shift, you're going to be more exhausted if I keep, alerting you and getting in your way.
Don't do that.
Don't do that, right? That's a bad thing. And so that's a second piece, is getting that cognitive piece right and that balance, right? I'm sure you face this, right? Where you have to there's this narrow window where you have to do the information just right and really try to lower that cognitive load, which is, hey, I've done some of the math for you, and I figured this out. Here's 2 or 3 ways forward, and just sort of leaving it there, opposed to, hey, you've got to do a bunch of thinking and interpret, whether it's the PDMP data or other data in the clinical record to make an informed choice. So those are pretty important things as we start to think about how to bring these types of models into the clinical workflow.
Just to add a quick comment to that, that's right. David Eddy said that the complexity of healthcare exceeds the capacity of the unaided expert mind. Everybody here knows that quote. The other side of that is that the artificial intelligence capacity to solve a problem requires that it have insight into what's in the neurons of the workforce. And part of the reason that is cognitive overload. I mean, how many alerts in a day out of the HR before they all mean nothing, right? And if the alert system is informed by where your struggle or misinformation resides in your brain, the number of alerts are no longer generic. They're specific to the individual physician or nurse. And that's part of, at Children's Colorado, here at Partners, in discussions tomorrow with Cleveland Clinic, we're looking at the smartest way to hook those things up. The alert system with what's in the brain of the worker.
I would say just to throw out one challenge with opioids as opposed to other things like A1C or blood pressure management is that we don't know what the right answer is. So the answer is not no opioids. So I think one of the challenges with pushing sort of what is your prescribing rate, which the state has done and others have tried to do, is that there is very real concern that the pendulum swings too far the other way, and that the response is, I'm never going to prescribe opioids because I'm scared of scrutiny, I'm scared of the DEA, I don't know what I'm doing, I've heard that these are terrible. And the result of that is that patients suffer, particularly patients who, so-called sort of legacy patients with chronic pain who have been on opioids for a long time. And under our new guidelines, we would not prescribe the way that they were prescribed to, and yet simply cutting that person off is not the right answer, even though it's the simplest answer. And we're seeing suicides across the country. We're seeing really terrible outcomes because of that. And so I think that's where the nuance comes in around how do you actually support people in making a very complicated decision that's not as simple as, prescribe less.
So I'm going to keep pushing on that line because I think that's very, very important for us to think about. So the biggest push on this work has been control the prescribing. It's inherently, pain management is inherently sort of what I would put in a bucket of kind of discretionary procedures in the sense of, there's lots of different options. There's not a mandate that you have to do it one way or the other. There's not a right answer. And it often happens, as Scott is describing, it happens in a setting of often increased stress, right? You're seeing a lot of patients. That sort of milieu is sort of the perfect milieu to grow and unleash our sort of cognitive dispositions to respond, our biases. And those biases are very clearly likely to come out in this particular space. And so whether we have biases by race or gender or income or insurance coverage, and we know, Scott and Sarah and I have looked at data, these kinds of data in our own system, and rather than go through the details of that data, what I would be really interested from the group is hearing, what is a potential data-driven approach to try to address this issue that we know is going to happen, which is that our internal biases are going to come out when we're thinking about prescribing of opioids for pain management, when there is this external pressure coming down to control our prescribing.
I would just throw in there, I think one of the challenges is that at least in some of the predictive sort of algorithms that I've seen, the factors that come out as predictive are ones that I fear will worsen our biases. So it's often things like the person has Medicaid, they're a smoker, they have depression, and they have a history of a substance use disorder.
Right.
They're all sort of no-brainer factors that of course increase a person's risk for substance use disorder because adverse life experiences increase a person's risk for substance use disorder.
Right. And so I worry, and that's sort of what I'm talking about, is there are these things that are really, you're right, those are markers for other things. But in the effort to control, I sort of air quote that a little bit, but to control prescribing patterns, how do we make sure that our biases don't feed into that, and that we create a scenario where we are not adequately treating pain for targeted patient populations? So what is the way that we can use our data to influence the way that prescribers are prescribing in a way that sort of counteracts bias?
Yeah, I think, well, one of the things that, I don't know if you know Vinod Khosla and Khosla Ventures, he wrote this great paper, I think it's called like 20% included, which is basically we should be aiming for the computer to do about 80% of the work, and then you got this 20% where the doctor is really the empathetic, connecting with the patient and doing the social determinants of health pieces. And I think our future is something around the pathway of, hey, the computer's gonna look at all the data points, right, and come up with a list of, like a menu of options, of paths forward, right? Because not all patients, right, need pain meds. Maybe there's another type of therapy or another prescription for them, for what's best for them. And that's really, we spend a lot of time looking at that, where we're just trying to say, hey, here's where the patient's at, here's your list of options, and we need to narrow that down. We work with some great children's hospitals, and I can tell you at one, when we started working with them, we looked at UTI, and only 10% of the time did the doctors actually get UTI prescribing right. And it was kind of a shock to everybody in the room. But the problem is, it's just, there's so many options in front of the doctor in that moment. They just, they're just sort of taking what they did last time or what they learned in their residency program. And so, we've got systematizing this is gonna be a process of taking all the great data that we're starting to quantify in the EHR and using models to get to these really narrow sets of menus, I think, of pathways forward, and then really giving that doctor, hey, here's your options, right? And then letting that choice happen. And then you get down to a much narrower window, right, of option, opposed to having the world at your fingertips, and you can prescribe any drug at any dose at any duration, and right. And we've started to see that, right, where states are locking down how many days you can prescribe things, and that's really starting to make an impact. But I think that's what we'll start to see, I think, in terms of shaping the right path forward to balance these factors and variables.
I would almost flip that a little bit, and the assumption there is that the 20% that the doctors are doing is empathetic and non-biased, but the reality is that doctors have tremendous unconscious bias, particularly when it comes to race, and particularly when it comes to prescribing for pain, where we know that we're less likely to treat pain if someone is not white. And so I wonder if there's a way to actually use machine learning to try to counter that, to actually make people aware of what their biases are based on the person in front of them. If someone is homeless or is a person of color, that's a patient that's actually less likely to get good care, and maybe that's where machine learning could help us.
Yeah. I think it's kind of funny, because what you get back to is it's not necessarily personalizing the experience for the patient, it's personalizing the experience for the provider, right? And back to your point, their bias and their background and things they might bring, and I think it's important the EHR almost understand that more than anything, and how they're gonna move forward, and also open those opportunities for micro-learning events and teaching them what the right way forward is. But I think it's such an interesting insight into so much of their bias and their background is just as important in some cases to what the patient needs.
If the end game is the aided expert mind, the question becomes aided how? And you talk about AI and all this expertise, but the expert mind has to want to receive it. We did a training across 23 health systems all in 1 month on recognizing sepsis. And we put a couple of experimental elements into the learning because we had such a large data set. And if you said to a physician, here, patient presents with the following conditions, what did the national guidelines say you should do next? You get about a 38% what we call struggle. I'm talking about not only did they not get it, and the doctor gets it wrong. You get about 38%, I think it was, cognitive dissonance to learn, really struggle. If you take the exact same question and you say, patient presents this way, what would you do next? And then the system says, you were sure and wrong. Now it's the same guideline you're using under the hood, but you don't mention the guideline. Then in the learning event, you say, by the way, would you like to see the guideline? A whole lot of the doctors will actually click and proactively look at the guideline. But if you tell them you're supposed to practice medicine to a guideline, then that aid doesn't come in. And so for me, AI is an intersection of the aided expert mind with the information coming in a way that they'll accept.
Can I ask a question?
Yeah?
So I struggle with this because I think that, especially with modern clinical decision support, there's basically two types. And one of them is, I thought was exemplified by a study we did looking at prescription drug monitoring programs many years ago, where we asked a provider if they were going to prescribe an opioid. And then we showed them the prescription drug monitoring program information. And we found that it changed decision-making in about 10% of the time. And in that 10%, about 60% of those were they decided to prescribe an opioid where originally they weren't going to. It's kind of the opposite. And I think what happens is that we as providers, we make up our minds. And if something shows up to me after I've made up my mind, I think I'm a lot less likely to accept it. Whether it be the allergy thing that I'm going to click through, or this other medication is better, I'm going to click through because I already thought about that. That's different than the sepsis ones that we have, where it pops up if sepsis is a consideration, and I think, oh wow, I didn't think about that. And so in that case, it's very helpful to me because it prompts me to remember or think of something that I didn't think about before. And I think there's a difference by how those interact with our minds.
We did a large-scale study of what we call regression. Confidently held misinformation will return, even after you've learned it away, will return at 23% of it will come back between 4 and 8 weeks. You go back to your practice, you start living your life, and a fourth of what we were able to overcome, if it was held confidently in error, will come right back. Yeah. You have to remediate that again.
I just want to change directions a little bit. So one of the questions that I always wonder about, and I think is on the minds of many physicians and patients, if let's say they're having a surgical procedure done, a routine surgical procedure done, is how much pain control will I need? And how do we judge that now? I would propose that what we do is very experiential and very individual. Like as an individual physician, would make some choice based on some experience I've had in the past, and it's not very data driven. So if you think about in the cesarean section space, how much do I need an opioid? Do I even need an opioid or not? And if I do, how many days will I need it for? And so we tend to both be, across physicians and surgeons, a little bit all over the map in terms of what we do, but within a physician or a surgeon, entirely consistent. And that strikes me as odd because each individual physician or surgeon treats a wide range of patients, but you're very consistent within your own practice, and that practice is very different from what everyone else is doing. So it doesn't strike me as data-driven, this essential question of what is the best way going to be? How much pain management do I need? And that to me strikes me as fundamental to all of these questions, because that's what we're hoping to achieve is good pain management. So what is the way in which we should be using advanced data and analytics or machine learning or knowledge learning platforms to better get at that issue? We take on projects where we say, that it just shouldn't be that after a tooth extraction that some patients get no opioids, some get opioids, and within the people who get opioids, some get 3 pills, some get 30 pills. I totally agree that doesn't seem like a good approach. But I'm not sure the solution is always just to say everyone should get 3 pills, which tends to be like the state regulation. That's the road that our state regulation has gone down now, right? Where you can only prescribe a week's worth of pills. How do we get to a point where we are using the information that's in our medical records, it's in the patient's chart, that's in the physician's mind, to actually prescribe a optimized pain management regimen? It's for anyone.
Mm-hmm. I thought about this before too, because so first of all, the old standard was that you'd have your appendix out and they give you 30 pills. It was always a multiple of 30 for whatever reason, right? 30, 60, 90. The moon, whatever, yeah. And then, you ask,
I think that's what it's based on.
You ask how many patients they've actually, how many they took, and it's a fraction of that. The vast majority of patients that get these surgical prescriptions after procedures don't use all the pills. So that's the first problem. Because I think it's clear, like we said before, the pendulum can't swing so far to the opposite direction where we're under-treating pain. But for patients with acute pain, whether it be an injury or a procedure, they often need it for just a couple days. And if you use the non-opioids first, and then you use an opioid on top of that, and then you wean off the opioid first, then that's usually safe. But everyone's, the threshold at which people's pain ends, the severe pain ends, is different for everybody. And so I would love for some way to be able to detect when that point is. And whether it could be from a wearable of some sort that's measuring the skin impedance. I know there's people who have done that before. There's some that have done like how many pills you're taking and then remind the patient not to take the opioid if they haven't been taking the other medications or they don't need them anymore. Something like that I think could be really nuanced and could be really helpful after procedures.
Yeah, I think this gets back to, one of the challenges in sort of the data we have today and the data granularity we really need. We look at like pharmacogenomics, right, as an area, right, that's just, it's a whole new frontier, and these tests are just starting to come out. We're all trying to interpret them, and how are we going to change our prescribing around them? And I think that's part of it too, of sort of, it's such a unique individual patient experience, right? It's so varied on how many pills am I going to take for how long, and there's a lot of patients that just don't want them at all, right? The chairman of my company just went through a shoulder surgery, and he just adamantly would not take any pain meds, right? Even though he got them, right? And I think you've got all the way to someone who wants to avoid pain altogether. And so I think we've got a long way to go in terms to, there's a lot more individual data collection we've got to do to get to a point where we will recognize these patterns, and then we can take the patterns back and say, okay, here's probably the best course for you as an individual patient.
Yeah.
But there's so much work to be done, and I think a lot of it has to do outside of the point of prescribing, right? That patient's experience as they go home and experience post-acute pain or whatever it may be.
I want to start getting to some of the questions that are coming in, just so that we don't run out of time. Since there's some interesting topics here. So there's a couple of questions that revolve around the theme of why has this been such a heavily United States issue around the opioid crisis, and how much of this has to do with the expectations that we set. If we set an expectation that you shouldn't be, and I will tell you this sort of discussions that we have in our own system is, if you're having a major surgery, should you be setting the expectation that you shouldn't be in pain? Because after all, we did, crack open your chest. It probably is going to hurt some. So do we set a different expectation? It does hurt to have surgery. Do you set an expectation that your pain should be manageable, not gone? And how much has that contributed to the issue that we're seeing here versus in other countries? If I go back to the cesarean section example, in many other countries, you just don't give opioid. Like it's not on the list of procedures for which opioids would be used, which is not the case in the U.S. So just something, Sarah, I wonder if you have some thoughts on that.
Yeah, I think that is definitely a huge component. Certainly when we have trainees come to us from other countries, they're often very shocked at how we use opioids. And we hear this from doctors who practice in European countries and other places where, to your example, if you break your ankle, people expect that that's going to hurt. And so first-line treatment in many other countries is acetaminophen and NSAIDs and not opioids. Whereas here, when people break a bone, we sort of assume that opioids will be a part of it. So I think changing patient expectation is a part of it. I think some of the percentages that we like to throw around, that the U.S. has 5% of the world's population, we consume 80% of the world's opioids. We do forget that in many countries, people have no access to adequate pain control even in the end of life. And so we have to put that data in context. So I think the answer is somewhere in the middle. I think the other huge component here is pharmaceutical companies, that sort of direct-to-physician and direct-to-consumer marketing happens in a way in the United States that it doesn't happen elsewhere. And there's been a number of interesting studies this year looking at that. So Scott Hadland at BU did a paper looking at the amount of physician non-research reimbursement that they receive from opioid-related payments from pharmaceutical companies, and it's directly correlated with how much you prescribe. And it's actually not the amount, but actually the number of meals. So if all you do is take a meal, the more meals you take from a pharmaceutical company that prescribes opioids, the more you prescribe opioids. It's a linear correlation. So there's a huge component for that as well. I think the way that we in the United States really interact with pharmaceutical companies in a different way than
predictive
physicians
analytics in a different form.
Yeah.
To predict the adverse consequences of pharma.
Yeah.
That's really interesting. So it does get back to the question, though, of how do we predict and how do we understand what is needed for good or adequate pain management.
Yeah.
And I do think it still comes back to the issue of what are the expectations that we're setting for patients?
absolutely.
And then once we set the expectation, how do we reach that goal overall?
I think to the C-section point at MGH, the OB department did an interesting project where they went to women and they said, on average after a C-section, most women take 3 tablets of oxycodone or whatever it was. You can have up to 30, what would you like? And most women choose 3. They choose whatever they're told is what they should expect. So I do think there's a huge component of how do we set expectations and let people know that if they're in pain, they can come back. It's not sort of a final decision, but engaging people around what to expect post-op or in the context of an injury is incredibly important.
Right. And I would say, maybe Scott, you can comment on this, but it is our hope that when we do electronic prescribing of controlled substances, that will reduce, hopefully eliminate a barrier that many physicians see, which is because I have to prescribe this with a paper signed prescription, that I need to give you all that you might need over the next month because it's very hard to get you another paper prescription. Have you seen that being helpful in terms of being able to do electronic prescribing?
Yeah, so we're just at the beginning of it now. We're rolling it out currently. If people know that in Massachusetts, it's the law that we do electronic prescribing of controlled substances as of January 2020. And so we're rolling it out currently. I think it's too early to see if it's going to work or not, but my theory is that for especially acute pain, where prescribers were giving, again, large amounts, 30, 60, 90 pills, because they didn't want, it was actually out of concern for the patient. They didn't want to have them have to come back to the office to do another visit so they could get another prescription, then go back to the pharmacy. So this would just allow them to prescribe directly to the pharmacy, even if the patient doesn't have to come back in. And that's a positive. So because it would be an incentive to prescribe fewer pills with always the safety net that we can add additional pills if needed.
Right.
We'll have to see how it pans out.
So I'll go to another question, and this is to anyone in the group who knows the answer to this. Do we have good predictive models for risk of overdose in patients who are using opioids?
So not great. I mean, I think we actually in Massachusetts have more information than most other states across the country. So a lot of the work around predicting overdose historically has been around prescribing. So what threshold of morphine milliequivalents increases the risk of overdose? So for people who are prescribed opioids, and particularly when they're prescribed another substance like a benzodiazepine that increases risk. Again, most people are not dying right now from prescription opioids. So if we want to predict overdose, looking at prescribed medications is no longer a helpful sort of place to be focusing on. Massachusetts, again, because of legislation, has what was originally called Chapter 55, is now called the Public Health Data Set, which links together a number of different pieces of data that allows us to understand in a much richer fashion who's dying from an overdose. And so we now know that the people who die from an overdose, first of all, overdose does discriminate. So we often hear people say addiction doesn't discriminate. Overdose absolutely discriminates. The people who are most likely to die from an overdose in Massachusetts are those who are recently incarcerated, pregnant and parenting women, those who are experiencing homelessness, and people with severe mental illness. And we know what fold increase you are in terms of likelihood to die from an overdose. So I think we're beginning to do that. And I do think in the public health sphere, beginning to look at big data is going to be a game changer in terms of better understanding how to predict these events, and then hopefully move that into real time, because that data right now, the most recent data is 2015. And since 2015, the crisis has already changed dramatically. But we could get to a place where you could predict in the moment who's most likely to die from an overdose, or even to get to sort of wearables and devices. We have a ton of information, on people's risks in their pockets that actually could tell us a lot about overdose. And if you get to the recognition of an overdose as something that no one should die from, it's a reversible event. We know how to reverse an overdose, so it really should not be something that is fatal. There's a lot of opportunity there, I think.
So what do you, I'm sorry, Scott, I just want to ask a follow-up question. It would sound like a really wonderful population management strategy to be able to identify these patients who are at risk of overdose. What do you think is the barrier to doing that right now? Like, what data would we need to be able to really accomplish that?
Well, I think
so that if you are prescribing chronically opioids to your patient population, you would be able to say, this is the 10% of patients that I really need to be worried about and put in different safeguards for them.
Yeah. Well, first I would say I think we need to run beyond prescribing. So I would say population health of all my patients, who am I worried is going to die from an overdose. I think one challenge is having different medical systems that don't talk to each other, because one of the strongest predictors of dying from an overdose is if you have survived an overdose. So if you've had a non-fatal overdose, your risk of dying from an overdose goes up dramatically. But although I can look in Care Everywhere, as Scott mentioned, and see records from other institutions, it's pretty hard to know if your patient went somewhere else with a non-fatal overdose, or if they got reversed in the field by EMS and never made it into the hospital. The unique thing about that public health data set is that it links a lot of that information, so EMS data, as well as data with hospitals and claims data. And so I think to begin to think about how do we pull together not just our hospital systems data, but data of what happens to people when they're outside of the hospital would allow us to be better, particularly around overdose. I think the other important piece when we think about trying to predict an event is what are we going to do if we find out that someone's at high risk? Because again, the answer is not necessarily just don't prescribe to them.
Right.
And I think doctors talk about confidently held misinformation or a knowledge gap. Most doctors feel very uncomfortable when you ask them, how do you talk about opioid use disorder? How do you treat it? How do you talk about harm reduction? Because some patients are going to continue to use drugs and we know how to keep them alive, but it's not information that doctors learn in medical school. And so I think there's a huge learning curve there as well.
Okay. I cut you off.
We were really fortunate to get some NIH funding to do a project similar to what we've done in Massachusetts, but actually in Oregon, where we've merged a bunch of the data sets together. And what we're looking at is not just the individual, because so much happens just at the individual level, right? Pulling in their medical records and their prescriptions. But we're actually starting to look at who else is in their household and what prescriptions are there, and then what prescriptions are in the community as well, and really try and get a better idea. The obvious question, follow-up question is what do you do with that information next? But at least I think we can be more targeted with our interventions when we gain that knowledge.
Okay. So I'm going to turn to another question, which is back to something we mentioned earlier, which is how do you optimize pain management in the pre, intra, and post-operative setting in the hospital? And so I'm just interested to know did your knowledge platform address these prescribing settings at all, or the standardization of prescribing opioids? Have you gotten into this hospital space at all?
Yes, so I'm going to pass the ball quickly because the answer is we built an initial courseware, and now we're bringing in OB specialist and American Association of Hospice and Palliative Medicine for that specialty. And our belief is that the learning really is environment specific for opioids. And so we're in the process of building that. Don't have data other than this generalized course.
Okay.
Yeah, no, we haven't done a lot there. I mean, I think one of our core partners is UC Health in Colorado, and one of the things that's interesting, the way they've handled sort of the prescribing of controlled substances is you actually have to sign off with your phone. And so it's been great as sort of another thing the doctors have never had to do together to kind of wake them up to, hey, you're doing something pretty serious right now. And it's both helping from an audit trail perspective, right, as well as dramatically lower the use of them because of this intervention and methodology they've implemented. So it's interesting, but around that in terms of pre or post-op, we have not pursued that.
One of the things I would say across partners that we have found very, very helpful is just, as Scott was mentioning in the emergency department, just looking at the data and showing it to people. We find remarkable variability. Some in the preoperative space, it's interesting to know how much pre-medication, or to look at how much pre-medication occurs in the, for major procedures, orthopedic procedures, or general surgical procedures. But when you start to look at the intraoperative, the PACU, and then on the wards, on the floor, the postoperative space, you see remarkable variation. And one of the important things about that is that variation is what is a pretty strong predictor of variation in what's prescribed on discharge, so what they go home with. And so one of the real opportunities, to get to the question of what is the opportunity with the pre, intra, and postoperative pain management scenarios, one of the real opportunities is that an intervention in the hospital space is a quite strong predictor of, in our models at least across partners, of what you're discharged on, but then even more importantly, who is still taking opioids 3 months after their procedure. So it's really remarkable to think that the decision that's made in the PACU around your opioid management is predictive of whether you're still taking oxycodone as an outpatient 3 months later. It's that kind of realization from the data that you can get from an electronic health record that proves the power of doing these kinds of analytics. So the solution may be to work on improving hospital discharge prescribing practices, but maybe it's actually the solution is working with our anesthesia colleagues and how pain is being managed immediately perioperatively. I don't know if you, Sarah, Scott, if you have any thoughts on that, Scott.
I was intrigued by a recent article that looked at patients undergoing gynecologic oncology procedures, and they looked at their numbers, their opioid use in the hospital, and what they sent you home with depended on how many opioids you needed in the hospital. So if you had, I think it was 5 doses or fewer, they didn't send you home on anything. And if you needed more than that, then they made sure you could transition to oral medications in the hospital and then sent you home with a reasonable number. So there's like real-time feedback that would show, as a physician that's discharging a patient, instead of just my cookie-cutter discharge, just tell me, wait, this is the morphine milligram equivalents this patient required in the hospital. You probably don't need to give so many at home, or you might need to give more for home. Things like that are more rational and patient-centered would be very helpful.
Right.
And I would say as a primary care doc who's often on the receiving end, I think once that sort of ball starts rolling, it's hard to undo it. So it doesn't surprise me that that's true, that a patient gets prescribed a certain amount in the hospital, they get discharged on it, and if that's a high amount, it's actually hard to undo some of that momentum. And having just returned from maternity leave, I'll tell an anecdote that a patient of mine had a routine shoulder surgery, and I returned, and it had been 2.5 months since the surgery, and he was calling for a refill of hydromorphone, and he'd been getting refills by various covering providers the entire time that I was gone, and no one sort of stopped to say, why is this guy still on opioids 2.5 months after his surgery? And he'd seen his orthopedist who said, you don't need opioids anymore, go back to your primary care. And so the opioids just got picked back up by primary care. And you can see how that happens so often. And then all of a sudden, this patient is on chronic opioids. And yet that decision was never thoughtfully made. It wasn't that someone said, wow, this is a person who really needs chronic opioid therapy, but rather just it began and then it never ended.
So change tracks again. What are the analytic data that we have on the efficacy of safe injection facilities, and what is the impact on the opioid crisis?
I'll dive right in there.
I was looking away from Sarah to first see if anyone
well, just first to level set. So safe consumption sites or supervised injection facilities are medically supervised settings where people who use drugs can bring in pre-purchased drugs and use them in a medically monitored setting. So basically accepting the reality that people use drugs in unsupervised injection sites all throughout our city, in our alleyways and public bathrooms. And so to provide a safe space for people who are going to continue to use drugs. There's about 100 of these facilities worldwide, so they operate in many countries across the globe. The only ones in North America are in Canada. There's quite a number in Vancouver and Montreal and Toronto and other places across Canada. And there's a number of cities across the US that are debating starting one, including Boston. So the legislation that was passed in Massachusetts had a commission that looked at the evidence and has recommended moving forward with a pilot. Whether that will happen or not is still up in the air. The evidence to date, so there's one large meta-analysis that looked at, there's been about 75 peer-reviewed articles on supervised consumption sites. And the first thing to note is that despite thousands, tens of thousands of injections and episodes of use within these facilities, there's never been a single death. So that's in contrast to 5 people will die today in Massachusetts using in unsupervised settings. So there's never been a death in a facility. There have obviously been lots of overdoses, but there are nurses on site who reverse the overdose. They seem to reduce deaths in the surrounding area and to reduce sort of public order crimes, so discarded syringes, public use, and they increase the likelihood that someone will engage in treatment. So most of these sites have either direct linkages to treatment or even treatment on site in the same setting. And so overall, the results have actually been quite promising, which is why, for example, Mass Medical Society was strongly in support of doing a pilot of a site here in Massachusetts after reviewing all of the evidence.
Great, thanks. So there's another great question I think it would be helpful for all of us to comment on, which is, what do you think the role is of engaging patients in addressing the opioid crisis? So I'll start with Scott.
Yeah, it's, the role is they're central to it. They're essential to it. Everything from, again, if you take an opioid after a procedure, or you have opioids that are in your home that then can be accessible by, an adolescent that's in the household, all the way up to I'm sure Sarah can always say better about this too, but reducing stigma, both in healthcare for themselves and for others. They're pivotal. And so the more we partner with patients on this issue, the better. I don't know how else to say it. It's important.
So I'm wondering, Bob, so how could your platform be used with patients in this space?
Yeah, we're under a lot of pressure from our membership to start doing patient training. Our shop is non-HIPAA compliant, so we don't see any patient data. It's a reasonable step. We do end user training in other verticals where that pressure of confidentiality of the data is less. So I think there's a role for it. We partnered with a group that focuses on direct patient education, but in our healthcare alliance, we've avoided it so far.
I wonder about, when we took our journey across partners starting a few years ago to really address the opioid crisis, one of the things we did was we addressed our current existing patient educational materials. And these were materials that were being handed out in our clinics that the prescriber would give about the risks and benefits. And many times the information in them was, less than accurate, less than fully accurate. And a lot of this has to do with sort of lobbying and the messages that were sent out around opioids going back to the 90s. I'm wondering I really do wonder how much confidently held misinformation there is among patients around both the risks of opioids as well as the benefits in terms of where are they useful in actually controlling pain and where are they actually not that useful.
Patient's definition of benefit.
Yeah.
Joke. But we are working with Dr. Callum McCrae here with this patient navigator program, which is kind of a step in between, right? Where you have a place the patient can call to engage with someone who's driving their care. I don't believe he's focused on opioids yet, more in cardiology, but he's had some incredible results here at Brigham with his work there.
Yeah, one of my favorite quotes, Toby Cosgrove's on my board, and one of my favorite quotes from him last year is, providers need to change and patients need to understand. And I think that's one of the biggest areas that, I love sort of the thing of sort of prepping the patient of, hey, women like you take 3 pills, and they sort of, that sort of prepping of, hey, you're gonna be in pain, we just opened your chest. I think there's so much we can do with patients. It's, for us, simple things, even like a patient navigating their pharmacy benefit and what they're gonna pay at the pharmacy. We deal with these things all the time. We have so much work to do around education. And I think also the fact that a lot of this stuff is outdated, right? There's so much education that was put out there. And we've got to combat the influence of pharma right here as well, right? Because there's a lot of education there that's happened both to the provider and the patient. And so I think that's, in my mind, one of the critical things we've got to do. And it has so much stigma around it. I just actually had a close friend who lost their sister, and it was like completely not talked about, unknown, right? It's sort of the silent thing. And it's much more common than you think about people getting addicted to these things. And so I think these public awareness campaigns and just really having an open conversation about it is such a critical piece to get to the right outcomes that we all want for this.
I would say engaging patients on the opioid use disorder part is also huge, because talk about confidently held misinformation. I would say most of what society, including most of us in this room, probably believe we think we know about addiction and treatment is wrong, but it's very confidently held. So people think that you go to rehab and that's how you get well, which is not true for opioid use disorder. And yet the types of treatment that are most effective, most people know very little about, or in fact there's outright stigma against them, like medication treatments for opioid use disorder. So I think there's a huge role for patient and family education around that. And then I think patient input from people who have opioid use disorder around our systems of care is another area that's really missing. So the whole notion of sort of nothing about us without us. We should be involving people who use drugs in designing these systems. And something as simple as having PFACs, patient family advisory councils, that are made up of people with substance use disorder, just like we do people who have a history of cancer, or people who have a history of cardiac problem, to help us really think from the patient perspective, what does it feel like, what is the experience like the way in terms of the way we deliver care and the options that people get.
Right. I would say, just drawing on something I think that you had brought up, Sarah, that's very challenging. We do our predictive analytics. We can identify the high-risk patients, but many of these patients are in a high-risk category currently, but were not 20 years ago when they started the medication. So I think of, one group that we target is the sort of triple threat, that's not really a great way to put it, but the crosshairs between being elderly, being on an opioid, and being on a sedative all at the same time. So it's one thing to have the predictive analytics set up to identify those patients, which we have and can do, like across partners. But then what do you do at that point when your patient is, taking, 3 milligrams of Ativan per day and also taking, 10 milligrams of oxycodone per day, and they're 78 years old, but they've been doing that for 25 years.
I mean, these are the challenging cases. This is what we hear from primary care docs when you talk to them about what do they struggle with in
I'm
practice.
actually asking you for a
Yes.
specific no, I'm just kidding.
I think first it comes back to shared decision making. I often think it's sort of like another area of medicine where our data has changed. So taking a less charged issue like hormone replacement therapy, where we were pushing women to get on it, and then all of a sudden the data changed and we were not prescribing it at all, and there was a cohort of people who were on it and had a hard time coming off, and it becomes really shared decision making with a patient about the risk and benefit. And I think giving providers the tools to feel like they know what to do in those moments. So I think a lot of providers don't feel comfortable tapering or even know what sort of an appropriate taper schedule would be. And so it's hard to sort of tell a patient you're doing something that's harmful if you as a provider don't really know what do you suggest as the next step. So I think, again, I don't think there's a single answer. We know involuntarily tapering people off these medications is not the answer. So saying, I'm just not going to prescribe for you anymore, not the right answer.
Right.
Not talking about it and just continuing to prescribe, also not the right answer. But somewhere in between of really educating people, these are the risks, this is how your risk has changed over the years, this is the new information we have that we didn't have when we first started these medications, and trying to work together.
So I'm just looking at the time. I want to ask a question that I think it draws back on something that came up earlier, which is one of the ways to really address this opioid crisis is to be creative in terms of all the data that are potentially out there, and how do we combine it into a sort of larger big data set that actually can help us address the crisis that's happening across all of our communities, and have a little bit less of a focus on just the prescriber patterns. And so, are there opportunities, and I know you're involved in RISE, but are there opportunities where we can learn from data collected by police and fire departments, along with the payers and the pharmacies, as well as the providers and the prescribers themselves? What would be the real kind of big idea, the real big opportunity, if we took all of those data all together, and let's say we had a magic wand and we were able to get all of those data together? What is the thing that we would be able to accomplish with big analytics in that space? So this is for anybody.
Yeah.
I could take a
Okay.
stab at it. The thing that it gets back to sort of things we talked earlier around is that, all these things get to sort of perfect prediction of what's right for this patient, right? And I think that's the hard pieces about this, where, we would understand the journey, as soon as they took that first pill, right? And what's right for them, or no pill at all, right? And so I think I think this gets to a lot of the data we wish we had today that we need to get to very quickly. I think some of these state endeavors are spot on in terms of pulling all these data sets together to start doing more prediction. And I think we've got to do a lot more work outside of the hospitals. There's just, there's good, not great, but good data that we've had. It's really that data outside on the patient experience, all the way out to the police and firefighters and what they're seeing to understand how we can better predict what the outcome is going to be for this patient. Because this is such a unique experience for each individual. I think that's the hardest thing about cracking this one. Is you've got the first time user all the way to the 7, 8-year-old that's been doing it for 25 years, and the last thing we should do is take them off it. It's just such a very, very hard thing to do. I don't know if you have any.
Yeah, I was thinking that first of all, I'm glad you brought up the data piece, because so many of these like AI or machine learning type projects, they all rely on something like administrative data, right? So it might be an insurance database. But especially with opioids, it's a really difficult one to capture, because a patient could receive Narcan, the reversal agent for an overdose, by an ambulance and then leave. And the only place it would ever be captured would be in that ambulance trip sheet. And so, and same thing, it's very hard to capture diversion of medications, obviously. So pulling in whatever we can above and beyond the administrative data is essential especially for this project, for this problem. And then the other part I would love to see is, I think the knowledge is power. And if we're able to say something like, okay, you're 40 years old, you're going to have a hernia surgery, These are factors from your past history, your past family history, your genomics, whatever. You have a X% chance of developing opioid use disorder after this procedure. Like, we tell people what the risk of infections will be, for example, but we never talk about things like that. So if, like, pie in the sky, I think that would be really powerful, because then if a patient knows that, then they would be probably even more careful about how they're taking their medication, and it just drives home the importance of that care.
Well, if we're talking pie in the sky, I would say, a lot of these events like EMS data, fire department, police, jail, all of these sort of touch points where we know people are at really high risk. So someone gets reversed with naloxone in the community, someone is getting released from jail, they got picked up on a possession or use or some other charge, that we would actually have the ability to, in that moment, interact with that person and offer them services. So whether that's a mobile fleet of units that can go out and can offer people harm reduction services, treatment on demand that's initiated right then, and really engage with people, I think we have the tools to actually save lives. We just have to get it to the people at highest risk. The one, and probably outside of stigma, a huge barrier in that is the fact that we still criminalize drug use in this country. So most people are still sent to prison, related to charges because of drug use. And so it's very tough, first, to have people trust us with their data or trust us with interventions. And second, the response when you see someone using in public is often not, how do I get this person medical services, but it's often a criminal justice response. And so I think there's a whole sort of policy and philosophy angle that needs to be addressed as well. But while we're talking about this as a public health crisis, I think there's a real opportunity.
Right. Remind me on what's the time? Oh, okay. So another question that's come in, and I apologize, I'm not going to get to all of these questions, but another question I think would be great for us to comment on, and maybe will be the last question, is if you had to pick an area, a clinical scenario where you think we should use a data-driven approach to drive decision support around this, whether it's patient decision support or physician, what is the area? And so I'll start here, and then we can go this direction.
I have a quick response that might set the stage. We evaluate every learning topic and every learning unit within the topic on this gradation of how big a part of the problem is knowledge versus compliance. And we weight the questions that cause harm because of knowledge much higher in our effort. I'll give you an example. Patient pressure injuries. Pressure injuries, hospital-acquired pressure injuries, is much more a compliance problem than a knowledge problem. Recognizing sepsis is much more of a knowledge problem, but a knowledge area where the EMR can be very effective. And there are other topic areas where the ER can't be there in time, and knowledge is a big part of the problem. What we know is about 55% of all adverse events are a knowledge problem from a large-scale CMS study. So we try to grade it, not just pick one, but in everything we do, down to the individual learning unit, grade each element based on that continuum.
I would say start treatment for opioid use disorder. It's not that complicated. A minority of people get it, and it's something that you actually could build in decision support, and we're beginning to do that in the emergency department setting for physicians. But this is a person who has opioid use disorder. Please consider starting this medication and connecting this person to care. Simple, could save lives.
Great.
Yeah, I mean, I love areas, one of the areas we started around systemizing prescribing is antibiotics, because it's so well understood, right? It's like you've got the antibiogram, you've got other very clear things that say, if this person has this condition, prescribe these things. And I think there's a lot of work we can do right away with technology and decision support to just chip away on those really well-known, understood things, right? Where, we all want to get to the AI future, but there's plenty of variability that we can reduce greatly just by saying, hey, for these conditions, do these things, and sort of get those guardrails in place, in technology, in the right place, right, in the workflow, in the EHR. And I think we're in those beginning stages, and that's where a lot of the work should I think focus immediately. And we've already started to see some good progress there.
Yeah, like just to your 80-20 point before too, like really looking at augmented intelligence as opposed to the artificial intelligence. I have a patient in front of me, I collect their vital signs, their history, their exam. Okay, and then the system tells me beautifully in a very effective and not intrusive way, this is what we think is going on, consider these diagnoses, like, take my job away. I'll do I'll do the procedures. I'll do the empathetic part. But maybe we'll get to that day someday.
Great. Thanks so much. And I think we're at time. So I'm going to wrap it up and thank all of our panelists here very much.